Good afternoon, everyone. First of all, I would like to thank Dr. Vittul for organizing this conference and inviting me here on this esteemed platform. I am going to talk about management of thyroid eye disease. We all know that thyroid disorders are very common, and a lot of patients suffering from hyperthyroidism or Graves' disease, they come to us with thyroid eye disease. And as clinicians, we always face this difficulty how to improve the cosmetic picture of these patients, because this disease is particularly more common in females as compared to males, and they are very worried about their eyes. When their eyes start protruding or bulging, it gives them a very a sense of lack of confidence. They come to us asking that what can you do for my eyes. So I think when we manage Graves' disease, it is very important to take care of this eye disease also from the very beginning to prevent and stop its progression. It is also called as thyroid associated orbitopathy or Graves' orbitopathy. So it is a very strong message in this only that it is not only an eye disease, rather it is an orbital disease, which means it is not involving only the eyes, rather the part behind the eyes, this is extraocular muscles, nerves, everything is involved. The whole of orbit is involved, and that's why nowadays it is called as thyroid associated orbitopathy. It is a major extrathyroidal manifestation of Graves' disease. Female preponderance is there, but whenever it is there in males and elderly, it is more severe. This thing we have to remember. So if we are seeing any male patient suffering from this eye disease, we will expect it that it is going to be more severe as compared to females. It is typically bilateral and rather symmetrical eye disease, and unilateral Graves' orbitopathy occurs in approximately 10% of the patients. So if any unilateral eye disease is there, it is an indication for imaging, because in most of the patients Graves' eye disease is bilateral. So if you are seeing a unilateral disease, you need to rule out other causes of unilateral proptosis. Coming to the clinical pictures, it can be easily remembered by a mnemonic, that is nose specs. It is being traditionally taught since many years. First of all, 0, no signs and symptoms. 1 is the only signs, no symptoms. Patients often complain of grittiness in the eyes, dryness in the eyes, and some pain. Then comes the soft tissue involvement, in which there is eyelid and conjunctival swelling and redness. And as you can see in this picture, there is typical eyelid swelling which is there, redness is there, and if you see by the slit lamp, there will be chemosis or conjunctival swelling will be there. Then proptosis, which is measured by an instrument called as Hertel's ophthalmometer. Proptosis is basically bulging of the eyeballs. Extraocular muscle involvement, which will lead to diplopia, impaired eye motility, which can be easily checked by clinical examination. Then the corneal involvement, which will lead to keratitis and ulcer, and it is one of the severe form of thyroid eye disease. Then the sight loss due to optic nerve involvement, which we call as dysthyroid optic neuropathy. It can be assessed by fundus examination, or sometimes imaging in the form of MRI may be done. So whenever we are treating thyroid eye disease, we have to know two things. One is the severity of disease, second is the activity of disease. There are two separate things. One is the severity, second is the activity. Activity is regarding the inflammation, whether it is an active inflammatory disease or inactive disease. Severity is the grading, like how severe is the eye disease. So it is classified into three forms: mild Graves' orbitopathy, moderate to severe, and the sight threatening. In mild disease, there is patient often complains of only symptoms, and signs in the form of minor lid retraction less than 2 mm, mild soft tissue involvement, exophthalmos, and less than 3 mm of the normal for race and gender, or no or intermittent diplopia may be there. It is classified as mild disease if any of this sign is there. In moderate to severe disease, patients are not having any sight threatening Graves' orbitopathy, but 2 or more of the features are there, like lid retraction more than 2 mm, moderate or severe soft tissue involvement, exophthalmos more than 3 mm, and inconstant or constant diplopia. And thirdly is the sight threatening disease, which may be due to corneal breakdown or optic neuropathy, optic nerve involvement. So you have to categorize the patient whether the patient is having mild disease, moderate to severe, or sight threatening disease. Then comes the disease activity, which I was telling before. This is basically because of the inflammation. So this is the clinical activity score. We have to calculate the score and only then we can tell whether the patient is having any active disease or the inactive disease. There are various pointers. One is a pain, spontaneous pain or pain on movement, redness of eyelids or redness of conjunctiva, swelling of eyelids, swelling of caruncle or plica, and swelling of conjunctiva, that is chemosis. These are the things, pain, redness and swelling, which are assessed at the initial visit of the patient, at the first visit. And when you follow up the patient, impaired functioning is checked, which is increase in proptosis of more than 2 mm in 1 to 3 months, decrease of more than 8 degrees in the eye muscle motility in any direction over 3 months, and decrease in visual acuity of more than one line in Snellen's chart over 3 months. So to say it is active disease, at presentation if the score is more than 3, we consider it as an active disease, and at follow-up if the score is more than 4, we consider it as an active disease. So depending on the activity and the severity, we treat this disease. Coming to the orbital imaging, a lot of clinicians, they perform CT scan or MRI in all the patients of Graves orbitopathy, but it is not always necessary. There are very specific indications when you need to do orbital imaging. One is to look for dysthyroid optic neuropathy. Second is in euthyroid patients or hypothyroid, if you are seeing proptosis, you should perform imaging to rule out other causes. In unilateral proptosis, again you need to do imaging, and it is often performed by CT and MRI. And whenever you are planning to perform surgical orbital decompression, you need to do orbital CT scanning to assess the bony orbit. What is the anatomy of the orbit? To assess the anatomy, you need to do imaging. So treatment, the most important thing is to control the risk factors. Smoking is one of the major risk factors which leads to worsening of thyroid eye disease. Also, all the patients who are suffering from hyperthyroidism or Graves' disease, they must be strictly told that they have to abstain from smoking. If they are smokers, they have to stop smoking immediately. Otherwise, smoking increases the risk of worsening of this disease by 3 to 5 times. Then thyroid dysfunction, you have to make the patient euthyroid. Don't make the patient hypothyroid. Even the hypothyroid state will also lead to worsening of this thyroid eye disease. Reduce the oxidative stress. You can give antioxidants to the patient. And radioactive iodine treatment. If the patient is having established thyroid eye disease, then you should be cautious of giving radioactive iodine, because it has been seen that if the patient of Graves orbitopathy is administered radioactive iodine, it leads to worsening of the eye disease. So in patients who are suffering from eye disease, it is better to avoid this radioactive iodine treatment. Then the local measures which are very important, we should prescribe artificial tears during the daytime, and at the night time patients can be given lubricants in the form of ophthalmic gels or ointments with possible taping if there is a gross proptosis and the patient is unable to close the eyes at the night time. Patients may also use swimming goggles at the night time, because the major problem is because of the air exposure which leads to keratitis. So since swimming goggles, they create an insulation, air cannot enter the inside the goggles, so they can also use the swimming goggles at the night time. And botulinum toxin injection, that is Botox injection, can also be given in the levator muscle, because it will reduce the tension and it will help in closing the eyes if there is proptosis is not that much. So Botox can also be given. Coming to the management of the mild Graves orbitopathy, general recommendations, as I have already told, they should be done along with local measures. Then mild Graves orbitopathy, there is no much treatment. You have to just normalize the thyroid profile of the patient, try to normalize T3, T4 levels. And there is a particular drug, that is selenium, which can be given in mild disease, and it has shown that if you give selenium in mild Graves orbitopathy, there is some degree of improvement which is seen in the patients. It is given in a dose of 200 micrograms daily for 6 months, and selenium is very easily available in a lot of nutraceuticals which are available in the market. And but if there is active disease, the severity is mild, but if you see the activities, then the patient is qualifying for the active disease, is the score is more than 3, then you can discuss with the patient regarding the steroid therapy. If the active disease is there, you can give steroid for a short term. Coming to moderate to severe and active Graves orbitopathy, which deserves the treatment, and the results are good if treated early. If you delay the treatment, then gradually the disease is going to become inactive, and no treatment is going to give any benefit. So all the treatments which are there for the Graves' orbitopathy, they are there for the active Graves' orbitopathy. If once the disease becomes inactive, that is, no inflammation is there, then we are not left with any therapy, only the surgical treatment is left. So it is very important to recognize this active disease in the very early stage. So the drugs which we have with us are the steroids, and the IV methylprednisolone is the drug of choice for the treatment of active disease. It is given in the it is given in an weekly administration. So cumulative dose of 4.5 milligram is given. Initially 0.5 milligram weekly is given for 6 weeks along with mycophenolate mofetil, and if response is there, we give an additional dose of 0.25 milligram weekly for 6 weeks. So it makes a cumulative dose of 4.5 milligrams. Once the response is there, then you need to stop the therapy. But if there is no response after the initial dose of like 0.5 milligram weekly for 6 weeks, then you have to go to the second line treatments, which I'll be showing in the upcoming slides. But if there is severe disease, then you can go up to higher dose of 7.5 milligrams also. In this, you give 0.75 milligram IV for weekly for 6 weeks, and followed by 0.5 milligram weekly for 6 weeks. But if again there is no response, then switch to second line treatments. But if the disease is inactive, there is no activity, there is no redness, only proptosis, severe proptosis is there, and patient is having diplopia, then we are left with only surgery. There is no other option in that case as of now. So coming to the second line treatments, we have a lot of drugs like repeated course of IV methylprednisolone. We can give oral prednisolone also, cyclosporin, azathioprine, oral radiotherapy is there. Then teprotumumab, it is a humanized monoclonal antibody, which is a newer drug, and I'll be discussing about this in the next slide. Then the rituximab and tocilizumab, these are still under research. All these drugs are being tried because they ultimately carry anti-inflammatory properties, and somehow if the patient is not responding to steroids, these drugs are being tried because the side effects are less as compared to steroids, and but concrete evidence has still not emerged with these therapies. But once the disease becomes inactive, go for the rehabilitative surgery. How to assess the treatment outcomes? One is a subjective improvement. Patients tell about the improvement, whether the grittiness has decreased, whether any improvement in the diplopia. And objectively, you can assess the improvement by seeing the clinical activity score. If there is improvement in more than 2 features in one eye without any deterioration in the other eye, then we can say that your patient is responding to the treatment. Coming to the systemic glucocorticoid therapy, as I've already told, that cumulative dose of 4.5 milligram methylpred given in 12 weekly infusions, 6 weekly infusions of 0.5 grams followed by 6 infusions of 0.25 grams are given. Then higher cumulative dose of 7.5 grams is reserved for more severe cases. Oral prednisolone has also been tried. It can be given in a dose of 1 milligram per kg, gradually taper down over to 5 to 10 milligrams per week until withdrawal over 6 months. But the response rates with IV methylpred are much more as compared to the oral therapy, that is 77% versus 51%. So when to consider second line agent? One, if the patient is has some contraindication to steroids, like if the patient is having any hepatitis, which is very common in hyperthyroidism, which the patient is already having transaminitis, then you should refrain from using steroids. Adverse effects outweigh the benefits, like some patients are having uncontrolled diabetes, and you cannot prescribe IV steroids because otherwise the blood glucose levels will surge too much. Failure of glucocorticoid therapy and recurrent disease. In such scenarios, you should consider second line therapies. Coming to another drug, that is mycophenolate mofetil. It is inosine monophosphate dehydrogenase inhibitor. It is also approved for the treatment of active disease, given in the dose of 1 gram BD for 24 weeks. But we have to monitor CBC and LFTs whenever you are prescribing mycophenolate mofetil. Cyclosporin and azathioprine, they have also been tried, but no definitive advantage has been seen in the clinical trials. Coming to teprotumumab, it is a newer drug. It is a fully humanized monoclonal antibody which inhibits IGF-1 receptor signaling. It was approved by US FDA in 2020, and OPTIC trial was the landmark trial which was conducted with teprotumumab. It showed significant improvement as far as proptosis is concerned, clinical activity score, diplopia, quality of life. And I must tell here that teprotumumab, it is the only drug for the management of Graves' orbitopathy which has shown improvement in proptosis. All the other drugs like glucocorticoids or any other immunosuppressive therapies, none of the therapy results in improvement in the proptosis. But teprotumumab is the one therapy which has shown improvement in proptosis. As you can see from these pictures, these are from the OPTIC trial. In the A, patients were given placebo. As you can see here, there was no improvement in proptosis. But in B, patients were administered teprotumumab, and at 24 weeks, you can clearly see the improvement in the proptosis. So it results in significant improvement in proptosis, but it is yet not available in India with us as of now. Coming to the management of sight-threatening disease. So if the patient is having sight-threatening Graves' orbitopathy, it may mostly optic neuropathy. So in this, you have to give pulse methylprednisolone, which is 0.5 to 1 gram once a day for 3 days. Consecutively, you should give, and monitor the ophthalmic parameters. Ideally, sight-threatening Graves' orbitopathy patients are admitted in the hospital. They are given methylpred 1 gram daily for 3 days. Daily ophthalmic assessment is done, and assess the patient after 1 week. If there is any response is there, then continue methylpred in a dose of 0.5 milligram weekly. Up to 6 weeks you should give. And if there is no response or partial response, then go for the surgery. Don't wait much, because otherwise the patient is going to lose the sight because of optic neuropathy. So it is a very emergency condition, and it should be handled very aggressively, otherwise patients will lose their sight. Coming to the role of surgery in the management of this Graves' orbitopathy, decompressive surgery is indicated in severe exposure keratopathy when the patient has developed corneal breakdown or ulcers are there, and dysthyroid optic neuropathy when patient is not responding to medical treatment. Local surgeries in the form of tarsorrhaphies, corneal patches or gluing may be done to prevent exposure keratopathy, and combination of decompression, ophthalmic plastic surgery and strabismus surgery is required in the ultimate inactive state, when you can say it is a kind of palliative treatment. If the patient is having gross Graves' orbitopathy and no activity is there, then there is a role of these palliative surgeries in the form of decompression or plastic surgeries. To conclude, whenever you are treating Graves' orbitopathy, restoration of euthyroid state is must. Control the risk factors, and local measures are most important. IV methylprednisolone and mycophenolate mofetil is the standard of care in moderate to severe and active Graves' orbitopathy. Biologicals, especially teprotumumab and to a lesser degree tocilizumab or rituximab, they hold a great promise in the future management of Graves' orbitopathy. Teprotumumab has been proven to improve greatly the results in Graves' orbitopathy, but it is not yet available in India with us. Thank you. Thanks a lot for the patient hearing. I'm happy to take any questions.